because it's a lot of information in this chapter. Hopefully, I broke it down pretty good. I think I'm just gonna go ahead and teach you guys pathology. I was working on it, and just so it can be consistent. And so I'm not gonna lie, too much pride. I didn't want to get my class up. It's always something. It's always something. Alright, so let me get to where we was. So guys, are there any questions about what we talked about last week? You know, started off just talking about the thyroid in general, embryology, where it kind of comes from. Remember the primitive floor invaginates on itself, it makes a little pouch. Okay, it travels down the thyroglossal duct. Okay, some anatomy right there. Also, we talked about some the cells that make it up. And this general anatomy. Again, guys, if I have it in blue, that's very, very important stuff. It's so much information on there. I think about this happening, I'm like, man, the small parts part of the abdomen test isn't even, I wouldn't even say it's gonna be 50 questions on there, right? So it's like, it's so much to memorize that you think you have to memorize. I would say try to focus on the main points. You're gonna have to know more for this class than you're gonna have to know for the actual registry, because that's why I say just focus on the main points. We said, what's the most common cause of thyroid disease? You're gonna say iodine deficiency, right? Because that's the most common cause of thyroid disease. You know, they just say Graves' disease associated with hypo or hyperthyroidism. You're gonna have to know that it's associated with hyperthyroidism. Okay? So just those most common things, that's what you're gonna have to know in this class when it comes to scrotum. Just, you know, same thing when it comes to, like, y'all start learning about the babies. You know, the most common tumor in the babies, a Wilms tumor. Just those most popular kind of things. All right? So we talk about some anatomic variations, how as the thyroid travels down, it can kind of leave some thyroid tissue in different locations. We talk about all the relational anatomy. I hope you guys know this relational anatomy as well. All right? The blood supply, the 4 arteries, the 6 veins that carry blood to the thyroid and from the thyroid, right? Okay. Also, again, it's important that you know where these vessels branch off from, the arteries, okay? And also, it's important that you know what the veins drain into. Okay. We got into some physiology, talked about what's the main purpose of the main job or the function of the thyroid. The 3 hormones that it secrete, T3, T4, and calcitonin. I think it's kind of where we left off at, right? Okay, so I think I was actually right here. All right, I think I kind of went over that. All right, so I'm gonna just start right here with calcitonin. I did this slide last time, right, guys? Yeah. Okay. I'm gonna start out with calcitonin, which is the 3rd hormone that the thyroid secretes. Okay. Key word for that meaning calcium, dealing with calcium in the body. Calcitonin, also known as thyrocalcitonin, guys. Thyrocalcitonin. It actually decreases the concentration of calcium in the blood by acting on the bone to inhibit its breakdown of calcium. So it actually prevents hypercalcemia. So hypercalcemia. So if the bone is actually producing more calcium in the body, it's going to activate the thyroid to secrete calcitonin. So it can break down that calcium being secreted into the blood. Okay? And just the opposite. Secretion will increase after any concentration of blood calcium increases. So those are our 3 functions of every hormone right there. Our T3, T4, and our calcitonin. Which one is more potent? T3 is more potent. T3 is more potent. I tried thyroxine, that word. Long word. The long word is more important than the short word. All right. so let's think about our laboratory data. Okay, the most common lab test to evaluate the thyroid is serum thyroxine, the T4 hormone. Okay. TSH, also known as thyrotropin, also indicates thyroid function and acts opposite of T4. Therefore, if the TSH is elevated, then that means that our T3 and T4 are going to be reduced, and they're not, meaning that the thyroid is not secreting as many hormones as it needs to. And vice versa. If the TSH is reduced, then likely our T3 and T4 hormones are going to be increased or over secretion of the thyroid, meaning like hyperthyroidism. Now, please stop me if you have questions. Please stop me if you have questions. But I'm
Is that TSH, is that another name for thyrotropin?
Yes.
Okay.
Yes, it's thyroid secreting hormone.
Okay.
Thyroid secretion hormone. All right. So these are just some terms I feel like you guys needed to know while we're going into getting into more important things, pathology. It's a lot of pathology associated with the thyroid. Good thing for us though is that a lot of the pathology looks just alike. You know, it's a lot of nodular thyroid. A lot of diseases are associated with the thyroid being nodular. A lot of diseases are associated with the thyroid being enlarged or being hypervascular. So a lot of these are basically off like overproduction or not enough production of thyroid hormone. So they're going to have a lot of similarities when it comes to appearance, but you do have to know the differences in these diseases. Okay, so euthyroid is just when the thyroid is functioning normal and it's getting the right amount of, it's secreting the right amount of hormones. Okay. And hypothyroidism is undersecretion of the thyroid hormones. Okay, deficiency of the thyroid hormone. Okay, it's the most common thyroid disorder. Is hypothyroidism. Hashimoto's thyroid is associated with hypothyroidism. Okay. Really, really important that you know Hashimoto's is associated with hypo. Graves is associated with hyperthyroidism, which is the oversecretion of thyroid hormones.
Hashimoto thyroid.
Hashimoto's thyroiditis. That's supposed to be thyroiditis. But yeah, Hashimoto's thyroid, same thing, thyroid. Okay. So just want you guys to know these terms before we start talking about the pathology, because a lot of the pathology is going to revert back to it either being an overproduction or under secretion of these thyroid hormones. Okay. And euthyroid, meaning that it's functioning normally. You're getting the right amount of hormone sent out into the body, into the blood. Okay. So, calcitonin is not a common indicator of thyroid function again, because calcitonin is really just regulating the amount of calcium in the blood, right? Right? If the bone is producing too much calcium, the calcitonin is going to secrete, the body is going to secrete more calcitonin into the body so it can get rid of all of that calcium in the blood. All right? But can be a lab test associated with medullary carcinoma with elevated calcitonin used as a tumor marker. Okay? So even though they won't test it for function, it can be a test that they will do for a medullary carcinoma because it is an indicator for tumors. Okay? When it's elevated. So if I ask a question that if calcitonin is decreased, then she'll be able to detect medullary carcinoma. That would be false, right? Because it has to be elevated. Okay. And these are just some lab values, guys. Right there, that's in your book as well. Just some lab values. I want to put that on the slides. Not precisely. Probably the thyroxine. The thyroxine. That's the most important one, right? That's the one they're going to test most of the time. But when it comes, we're talking about function, guys. It's not ultrasound that we test for function, right? Because ultrasound is good for detecting whether it's something cystic or whether it's something solid. You know, getting good measurements of the thyroid. When we're thinking about function of the thyroid, the test for that would be a nuclear medicine. Okay, that's when they test for the function. And the two tests they do in nuclear medicine are going to be an iodine uptake scan and a thyroid scan using that technetium 99M as their is that a contrast agent? Is it a contrast agent? Okay. Yeah, it's a contrast agent. I didn't know it. It's a radionuclide, right? Yeah, that's the radionuclide. But nuclear medicine is more is the best modality for checking thyroid function. Okay. Thyroid physiology. Ultrasound is good for, you know, discerning nodules, masses, cysts, you know, the appearance of the thyroid. So, let's talk about the sonographic evaluation. Basically, that's what you do during the exam, before the exam, and during the exam. Okay, so before the exam, guys, good thing about the thyroid exam is no patient prep needed. You know, we don't have to be NPO for any amount of time. Anybody can just come up there and get their thyroid evaluated. Okay? It's a non-invasive exam too. Not like a transvaginal where you have to, you know, go inside the body cavity. Okay? What you should do before you do anybody's exam is always review the previous exams. Okay? If they have a previous thyroid, because what you're trying to do is you're trying to match, like say for instance somebody has 30 nodules. Y'all seen those thyroids that is just really, really ugly, right? They have a bunch of nodules. So what you know with ultrasound, all we're gonna do is try to find the biggest three of anything. If you have 3 kidney cysts, I'm just gonna find the 3 biggest kidney cysts that you have. If you have 3 liver masses, I'm just looking for the biggest 3 liver masses that you have. So what we're trying to do is match this exam up to the next exam, right? To see if those 3 masses have grown or have they gotten larger. Okay, so don't be overwhelmed when you see a thyroid and it's really bad. You're like, oh my God, I'm gonna be here all day. No, because some places only want you to measure 2, right? So always look at your previous exam because that's gonna help you kind of do your exam that you're about to do. Even though, like me personally, I really don't like looking at previous exams always because it kind of gives you a little bias, you know. But if it comes to like measuring masses and things like that, then I will because, you know, it's important that we match it. I don't want to measure new masses that this person didn't measure the previous time. Because you'll see everybody scan them differently. Some people have a cyst on the kidney, depending on the size, they won't even show it to the doctor, right? They'll just decide for themselves, oh, that cyst is not big enough, so I'm not going to show it to them. They'll take every image all around that and won't show it to the doctor. So I like to look at stuff, you know, like a mass or something. I'll do that, but most exams like an abdomen or something, I like to go in there blind and just kind of do my exam myself, and then I'll check the images after I finish. Okay? Always thoroughly explain the exam to the patient. You know, I don't even have to elaborate on that. You know, just tell them what you're doing it, why you're doing it. You know, you can answer any questions that don't pertain to results, and do your best to try to answer those questions for the patient.
Service first.
Service first. Always try to build that rapport with the patient, especially you guys as students, because that's what's gonna make them trust you. You know what I mean? It's already, especially if somebody say, "Hey, this is my student," you know, the patient's already like, "Oh man, you know, it's my student, man. Golly, do you have to scan me? You know, can I get somebody else? You know, so especially you want to just build that relationship. All right." Get an adequate patient history and ask open-ended questions. Like, don't tell the patient what's going on. Ask them in open-ended questions what's going on with them. You know, say for instance, you know, can you tell me the last time you had, you know, a thyroid exam? You know, what did they find on the last exam that you had? Instead of just telling them, oh, even though I may already know the results, you know, because a lot of times, as you guys can see, a lot of people don't even know why they're there. They just at the hospital getting exams, and Oh, I'm here for my stomach. I'm here for my abdomen. Oh, okay. Well, you know, let's do it, y'all. So let's get down. You know, so definitely try to inform that patient on why they're there. All right. That's all the stuff you do before the exam, right there. So during the exam, I'm always gonna have the patient in the supine position and elevate the shoulders. I say supine, but as supine as that person can go, because everybody can't lay flat, right? Mm-hmm. So I would say as supine as that person can go. I always like to have a little angle up on the bed because I like to build their shoulders up, roll up a sheet or something and build their shoulders up so I can have them extend their neck, okay? If you have them supine and you have them extend their neck, then they're gonna be laying on the table upside down basically, and the nose will be in the air, and it's hard to, well, we're all pretty young in here, so we can do it. But when you start doing these patients, they won't be able to do that, especially somebody like, that has goiter or something like that. Okay, so put that patient in the supine position as you can and elevate those shoulders. Roll up a sheet or towel, and put it under those shoulders because that's gonna help you extend the neck back so I can get all of that room because again, I wanna get as inferior, posterior to the sternum as I can. Okay. Select the highest frequency transducer available. Usually that's a linear 12 transducer, or some places may have a linear 17 transducer. So whichever one, the thyroid is that superficial that you can use a 17 transducer on it because it's only like 3 or 4 centimeters deep anyway. Mm-hmm. Okay. So remember, the highest frequency transducer, the better images you're going to acquire, the more detail you're going to be able to see. Is really important on the thyroid because sometimes you may see something that may look like a cyst, but it may have like a capsule around it. It may be something encapsulated in that cyst. You may see 3 cysts, but it may be really one mass that contains those 3 cysts. So the better, higher frequency transducer you have, the more you're able to see that detail in those exams. Okay. Carefully evaluate each lobe and the isthmus in the transverse and longitudinal plane.